Okay, before I begin, I would like to thank Professor Kostis for inviting me here today. I will talk about a patient with type 2 diabetes and heart failure, and I will solemnly focus on the anti-diabetic treatment of this patient. There are my disclosures. So we know that diabetes is one of the most common non-communicable diseases. Also, we know that cardiovascular disease is the most common cause of death. These two statements make the management of cardiovascular disease in diabetes of a great challenge for the physicians and the cardiologists. Some hard facts from the International Diabetes Federation published in 2021. There are approximately 537 million adults living with diabetes. The total number is projected to rise to 643 million by 2030 and 783 million by 2045. Almost 1 in 2 adults, approximately 240 million, are living with diabetes and are undiagnosed. Diabetes causes 6.7 million deaths, and there are 541 million adults with impaired glucose tolerance, which places them at an increased risk of developing type 2 diabetes. In Europe, we have 61 million living with diabetes, and this number is projected to rise to 67 million by 2030 and 69 million by 2045. We have 1 in 3 adults living with diabetes that they are undiagnosed, and we have 1.1 million deaths due to diabetes in 2021. We have the meta-analysis of 18 clinical trials evaluating the risk of cardiovascular disease among patients with impaired fasting glucose or impaired glucose tolerance. And both of them, the pre-diabetic conditions, we found that both of them increase the risk of cardiovascular disease. So when we make the diagnosis of type 2 diabetes in our patient, the previous 10 years, he had pre-diabetes with all the complications that go with them. So microvascular and microvascular complications. So our patient already has micro and macrovascular complications. The mechanism by which diabetes can lead to coronary heart disease are multiple: infection, inflammation, hyperglycemia, insulin resistance, dyslipidemia, thrombosis. All those go to create subclinical atherosclerosis, and as we have the progression of the disease, we have atherosclerotic clinical events. In this cohort study, Malik and his associate reported that the risk of cardiovascular events increases when the total mortality in people that have both pre-existing cardiovascular disease and diabetes in comparison with people that have only metabolic syndrome or have only diabetes or have only cardiovascular disease. So as we can see here, patients that have diabetes and cardiovascular disease live 12 years less than normal people that don't have diabetes, and 6 years less than people that have diabetes. The UKPDS study showed that the risk of cardiovascular disease increases as we have an increase in the glycosylated hemoglobin. And also in a study in 2015, which was a cohort study using more than 1.5 million people, both diabetic and non-diabetic, we found that in type 2 diabetics, heart failure was the second cause of heart presentations below peripheral arterial diseases. So patients with heart failure are at risk for morbid and fatal events. There are as many as 1 in 5 people which will develop heart failure during their lifetime. Heart failure is estimated to affect 64 million people worldwide in 2016. heart failure morbidity and mortality rates are high despite the advances in therapy. In US, the 5-year heart failure mortality after diagnosis is less than 50%. Heart failure mortality risk is similar to some of the common cancers, both in men and women. So patients and policymakers lack the awareness of heart failure. And when we say heart failure, the new universal definition classifies the different phenotypes according to the left ventricle ejection fraction. So we have heart failure with reduced ejection fraction when ejection fraction is less than 40%. Heart failure with mildly reduced ejection fraction when it's somewhere in between 41 and 49. And heart failure with preserved ejection fraction when it's above 50%. The guideline-directed medical therapy, well, a few years back, was RAS inhibition, which decreased the afterload, beta blockers, which decreased the work of the left ventricle, and mineralocorticoid inhibition with diuresis. And so we go to the standard of medical care in diabetes in 2022 that states heart failure is another major cause of morbidity and mortality from cardiovascular disease. Studies have found that the rates of incident heart failure hospitalization were 2-4 higher in patients with diabetes compared with those without. And the diabetic can have either heart failure with preserved ejection fraction or with reduced ejection fraction. Hypertension is often a precursor of heart failure of either type, and atherosclerotic cardiovascular disease may coexist with either type, whereas prior myocardial infarction is often a major factor for heart failure with reserved ejection fraction. So, for the prevention of management of both atherosclerotic cardiovascular disease and heart failure, we should systematically assess at least once a year all our patients for all the classical risk factors, which is diabetes, obesity, overweight, hypertension, dyslipidemia, smoking, family history, etc. The pillars of treating diabetes and its complication include the glycemic management, blood pressure management, lipid management, and agents with cardiovascular and kidney benefit. As I said before, I will focus solemnly in the glycemic treatment. So in metformin, there used to be some restrictions, but they were removed by FDA in 2006. So observational studies of patients with type 2 diabetes and heart failure suggest that metformin users have better outcomes than patients treated with other hyperglycemic agents. However, no randomized trial of metformin therapy has been conducted in patients with heart failure. Metformin may be used for the management of hyperglycemia in patients with stable heart failure, as long as kidney function remains within the recommended range for use. Also, we see in the 2023 guidelines from the cardiologists that patients that already prescribed metformin, SGLT2 inhibitors, or GLP should, the GLP inhibitors and SGLT2 inhibitors and GLP agonists should be added to metformin if there is a need, independent of the need for the additional glucose control. In patients with type 2 diabetes and atherosclerotic cardiovascular disease with no metformin, an SGLT2 inhibitor or a GLP receptor agonist should be given first line, and metformin should be considered for those who thereafter warrant additional glucose control. So we see that what we knew, that metformin was the first step, now it's starting to change. Sulfonylureas, old drug, but given the lack of data of any demonstrable benefit, are not recommended as initial therapy in patients with stage C heart failure with reduced ejection fraction. Based on findings of statistical non-inferiority of linagliptin versus placebo in Carmelina, well, okay, you can use, there is a safety regarding the cardiovascular disease, but the long-lasting uncertainty is no longer critical relevant for glimepiride, which was used in this study. Thioglitazones. Data on the effects of pioglitazone will have a strong and consistent relationship with increased risk of heart failure. Therefore, they should be avoided in patients with symptomatic heart failure. We know that thioglitazones increase the risk of heart failure, with the incremental risk of heart failure with pioglitazone at an estimated 0.4 annualized absolute increase. So heart failure associated with pioglitazone appears to be attributable to expanded plasma volume with no evidence of myocardial toxicity. The weight gain to adipose tissue expansion, but with weight redistributed predominantly to less metabolically active adipose tissue, and we have weight gain that may be greatest concern of patients and clinicians with this class of drugs. So based on the data, patients with type 2 diabetes and prevalence of atherosclerotic cardiovascular disease, we do not suggest to take this kind of drug. DPP-4. There are a lot of recent studies examining the relationship between DPP-4 inhibitors and heart failure with mixed results. The SAVOR TMI 43 with saxagliptin showed that saxagliptin were more likely to be hospitalized for heart failure than those given placebo. So we do not suggest saxagliptin, but all the other cardiovascular outcome trials, for example, with alogliptin, with sitagliptin Tecos and linagliptin Carmelina, did not find a significant increase in the risk. So we can think about them in some patients. GLP receptor agonists, there is no increased risk of hospitalization, which was found in the meta-analysis of the phase 2-3 trials by exenatide, dulaglutide, liraglutide, and demonstrated the safety of this pharmacological class. Leader particularly reported a trend towards a reduction in heart failure hospitalization, together with a significant reduction in cardiovascular and all-cause mortality in patients with type 2 diabetes at risk of cardiovascular disease. Yesterday, as I was surfing the internet, I found this article published in the New England Journal of Medicine. Semaglutide in patients with heart failure with preserved ejection fraction and obesity. Well, it was randomized of 529 patients that had heart failure with preserved ejection fraction and increased body mass. And the primary endpoints were the change from baseline in the Kansas City cardiomyopathy questionnaire, and the higher scores indicated fewer symptoms and physical limitations. The conclusion of the article is that in patients with heart failure with preserved ejection fraction and obesity, treatment with semaglutide in a dose of 2.4 milligrams led to larger reduction in symptoms and physical limitation, greater improvement in exercise function, and greater weight loss in placebo. So we expect more from this type of drug in the future. So insulins. In patients with established heart failure, there are little evidence about the safety and efficacy of insulin use. There are no RCTs with insulin use in patients with heart failure, but we have observational studies which often confound by indication, as insulin is more likely to be used in patients with more advanced type 2 diabetes and severe comorbidities. The Origin trial showed no impact of basal insulin glargine on cardiovascular outcomes and heart failure events in patients with cardiovascular risk factor in comparison to standard of care. Given insulin's correlation with hypoglycemia and weight gain and lack of demonstrable cardiovascular benefit with use, other agents such as metformin, SGLT2 inhibitors, and probably GLP should be preferred unless appropriate glycemic control cannot be achieved solely by those agents. And we see from ADA's last published guideline that a heart failure, they suggest an SGLT2 with heart benefit and to add on other drugs if glycosylated hemoglobin is above target. Why that? We have the EMPEREX study, the first cardiovascular study that reported the outcomes of SGLT2 inhibitors with people with type 2 diabetes. The study investigators noted a significant reduction in 3-point composite MACE compared with placebo, and therefore a significant relative risk reduction for cardiovascular death, 38%, heart failure, 35%, and all-cause mortality, 32%. It was a revolution. Then we had the CANVAS program with canagliflozin that was reported to demonstrate superiority for 3-point MACE, with its use found to result in significant reduction in cardiovascular death and hospitalization from heart failure. Subsequently, similar observations were made in Credence trial, in which canagliflozin use was associated with a significantly reduced risk of cardiovascular death, myocardial infarction, stroke, and hospitalization for heart failure. Then we had the GLAIR TMI trial, which investigated the use of dapagliflozin compared with placebo and demonstrated a non-significant reduction in the rate of the 3-point MACE and a significant lower rate of hospitalization for heart failure in people with type 2 diabetes. And this trial went on with the DAPA heart failure study, which explored the use of dapagliflozin in people with or without underlying diabetes and the diagnosis of heart failure with reduced ejection fraction. The study investigators observed a significant relative risk versus placebo for cardiovascular death and worsening of heart failure over 18 months in participants using dapagliflozin, with similar results in people with or without underlying diabetes. And that's the summary of the study. Then we had EMPEROR reduced with epagliflozin, which exactly the same, not exactly the same trial, but with people with ejection fraction with reduced ejection fraction using epagliflozin and placebo. The compository primary endpoints was time to first event of adjudicated cardiovascular death or adjudicated hospitalization for heart failure. And secondary endpoints were first and recurrent adjudicated hospitalization for heart failure and the change from the eGFR from baseline. So in this trial, we found that both the primary and the secondary endpoints were confirmatory, and the slope in eGFR. So we had 30% reduction in all-cause death, 40% reduction in cardiovascular death, and 20% reduction in hospital failure hospitalizations. Then they went a step more with EMPEROR Preserve the Phoenix, examining people with preserved ejection fraction, as shown in the study with close endpoints. Also confirmatory for this trial. And they went a step further with the Impulse trial with starting empagliflozin in people that they're hospitalized in the hospital. Right now, the initiation was in the hospital. We're talking about acute heart failure, regardless of the ejection fraction of the patient. So this was a complement in the Emperor trials for examining the effects of epagliflozin over the whole heart failure disease journey. And of course, it had very good results. So patients hospitalized for acute heart failure treated with epagliflozin were 36 more likely to experience a clinical benefit versus patients on placebo. The clinical benefits were consistent with patients with either reduced ejection fraction, mild ejection fraction, or preserved ejection fraction, and in patients with de novo or decompensated chronic heart failure, and was well tolerated with overall safety data consistent with other studies. So this drove the American College of Cardiology, the Canadian Society, Cardiovascular Society, and the European Society of Cardiology to include SGLT2 as in the foundational therapies for the treatment of patients with heart failure and reserved ejection fraction. The key physiological effects of SGLT2 inhibition is that they increase glycosuria, and they decrease the glycosylated hemoglobin, they decrease the glycotoxicity, they lose body weight, and we have natriuresis and osmotic diuresis with decreased blood pressure and glomerular filtration and decrease the plus volume. So this unique diuretic effects is that they selectively reduce interstitial volume with minimal change in blood volume. There are no counter-regulatory stimulation of the RAS and nitric oxygen activation in the sympathetic system. There is no hypokalemia. We have improved renal function and reduced uric acid levels. So the mechanisms of actions are multiple also. We mentioned them above. And so we see why SGLT2 were first level treatment for people with heart failure. As you can see, metformin use is still recommended for the as a first step for the diabetologist, not for the cardiologist. Yes, and the holistic approach, as we know. And finally, my final slide is what we can use as anti-diabetic agents for type 2 diabetes with patients with heart failure and have all the drugs and the average reduction in glycosylated hemoglobin, the contradictions, the adverse events, and the guidelines recommendations. Thank you for your